Hello, and welcome to the topic Sjogren syndrome in the Rheumatology module. By the end of this topic, you should be able to define Sjogren syndrome, explain the pathophysiology of the disease, outline the causes and classification, describe the clinical manifestations, outline the investigations to diagnose, assess the severity and monitor response to therapy, discuss the principles of management, and explain the complications and the prognosis of Sjogren syndrome. Let's get started. First, let's look at the definition of Sjogren syndrome. It is a systemic, chronic, inflammatory disorder characterized by lymphocytic infiltration of exocrine organs, for example, the lacrimal and the salivary glands. Named after a Swedish ophthalmologist, Henrik Sjogren was the first to identify the triad of keratoconjunctivitis sicca, xerostomia, and polyarthritis in a group of women. Moving on to the pathophysiology of Sjogren syndrome. The initiation factor is often exogenous, most commonly viral in nature. Examples include cytomegalovirus, hepatitis C virus, and Epstein-Barr virus infections. Immunologic, genetic, and hormonal components are also thought to be involved in its pathogenesis. Damage and cell death due to said viral infections release antigens that are picked up by toll-like receptors on dendritic or epithelial cells. These dendritic or epithelial cells are then activated and begin producing cytokines, chemokines, and adhesion molecules. This in turn causes lymphocyte activation as they enter the gland. Thereafter, they become antigen-presenting cells. Common antigens seen in Sjogren syndrome include SSA-Rho, SSB-La, alpha-fodrin, beta-fodrin, and cholinergic muscarinic receptors. There are several methods infiltrating cells interfere with glandular function, ultimately causing destruction of glandular elements. First, secretion of cytokines that activate IF1 and IF2 pathways. Secondly, production of autoantibodies that interfere with muscarinic receptors. And lastly, secretion of metalloproteinases that interfere with interaction of glandular cell and its extracellular matrix. As the disease progresses, mucosal surfaces become sites of chronic inflammation and a vicious cycle begins. Now, we explore the etiology of Sjogren syndrome. Polymorphic major histocompatibility complexes or MHC genes are highly associated with the development of autoantibodies found in Sjogren syndrome. Prolactin is an immune stimulator that is involved in T cell proliferation. It induces interleukin-2 receptor expression, supports interferon gamma production, and stimulates antibody production. This suggests the estrogen-prolactin relationship strongly affects the cause and initiation of autoimmune diseases. Viruses such as cytomegalovirus, hepatitis C virus, Epstein-Barr virus, and human T-cell leukemia virus type 1 can cause autoantibody production through molecular mimicry. Sjogren syndrome is classified into primary or secondary. Primary Sjogren syndrome occurs in the absence of an underlying rheumatic disorder. Secondary Sjogren syndrome, on the other hand, is associated with an underlying rheumatic disorder such as rheumatoid arthritis, scleroderma, and systemic lupus erythematosus. The ACR-EULA classification criteria for primary Sjogren syndrome include inclusion variables that are weighted. A total score of 4 and above classifies a patient as meeting the inclusion criteria and is suspicious of Sjogren syndrome provided they do not meet any of the exclusion criteria. Next, we will look at the clinical manifestation of Sjogren syndrome. Patients often present with sicca symptoms, which simply means dryness of the eyes and mouth. Common complaints include being unable to eat dry food as they stick to the roof of the mouth, difficulty speaking for a prolonged period, hoarseness of voice, toothache, and altered sense of taste. They may also complain of redness or painful gritty sensation in their eyes. Recurrent cheek or neck swelling may be attributed to salivary gland swelling. Non-vasculitic cutaneous symptoms include dryness, eyelid dermatitis, and pruritus. Pulmonary symptoms are cough, sore throat, and shortness of breath. Cardiac symptoms include palpitations, swelling of the extremities, chest pain, and shortness of breath. Now, upon examination in the orifice, a clinician may find corneal lesions and decreased tear pool. A dry tongue would present as red, smooth, and dry, and this may also be associated with scaly lips, bad breath, dental caries, and chronic oral candidiasis. There may be parotid duct narrowing, with bilateral parotid gland enlargement. Nasal dryness, aphonia, and atrophic rhinitis are among other signs elicited in the orifice. Moreover, there may be atrophic changes in the vulva and vagina resulting in pruritus and vaginitis. Besides that, the anus and rectal mucosa may also present with dryness and hence pruritus and inflammation. Extraglandular signs include esophageal dysmotility, pancreatic involvement, splenomegaly, and hepatitis. Pulmonary signs include recurrent chest infections, restrictive ventilatory defect, impaired gas transfer, and bibasal crepitations. Signs of arthritis and UTI may also be present. Moving on to investigations, ophthalmic involvement is tested by Schirmer's test, which quantitatively measures tear production over a specific time period. A rose Bengal eye stain will reveal breaks in the corneal epithelial surface. Oral involvement is tested using a salivary cyelometry. Low salivary flow is defined as less than 1.5 mL per 15 minutes. Labial minor salivary gland biopsy in Sjogren syndrome will reveal lymphocytic cyeloadenitis with a focus score grade or equal to 1 per 4 mm square of tissue. Systemic tests include identifying the presence of Rho SSA and LA SSB autoantibodies and rheumatoid factors in the patient's serum. Useful bedside tests that could be done are Schirmer's test, rose Bengal eye stain, and salivary cyelometry. Lab investigations include obtaining titers of anti-SSA Rho and anti-SSA La antibodies. Routine blood investigations such as a full blood count may demonstrate pneumochromic pneumocytic anemia with leukopenia. The presence of rheumatoid factor and an elevated ESR may also be seen in these patients. A salivary gland biopsy with a score grade or equal to 1 focus per 4 mm square establishes the diagnosis of Sjogren syndrome. Imaging studies may include cyelography, whereby a radio-opaque dye is injected into the salivary glands and visualized to exclude obstructions and strictures. Salivary scintigraphy gauges salivary flow and provides an objective measure of salivary gland dysfunction. Ultrasound of the parotid gland will reveal a honeycomb-like structure of the glandular parenchyma, alternating hypoechoic areas and band-like hyperechoic septa and cysts. Functional studies look at other organ systems, such as urine analysis may reveal possible signs of glomerulonephritis and interstitial nephritis, such as proteinuria and red cell cast. Pulmonary function tests are useful as Sjogren syndrome predisposes patients to interstitial lung disease and hence manifest restrictive ventilatory failure. This is characterized by reduced total capacity and forced vital capacity with a normal forced expiratory volume in 1 second. Although rare, primary Sjogren syndrome may have obvious cardiac involvement with clinically silent manifestations such as symptom-free pericarditis and left ventricular diastolic dysfunction, and this is where an echocardiogram would be essential. Now let's look at the medical management of Sjogren syndrome. The mainstay of Sjogren syndrome is, in terms of treatment, is largely symptomatic and focuses on prevention or treatment of complications. Moisturizing creams help with dry skin. Vaginal lubricants can be used for vaginal dryness, and vaginal estrogen can be considered in postmenopausal women. Do watch out for vaginal yeast infections. First-line therapy for dry eyes are artificial tears. When deemed insufficient, ophthalmic cyclosporine drops may be added. Patients are also advised to maintain surrounding humidity, shield their eyes from the wind, and take regular breaks when reading. In moderate disease, consider topical immunosuppression using cyclosporine and lubricants. Systemic immunosuppression are reserved only for severe cases and not used routinely. Dry mouth can be treated with salivary substitutes as a first-line therapy. If as a sole therapy proves insufficient, artificial saliva can be continued as an adjunct to muscarinic drugs and immunosuppressive drugs such as hydroxychloroquine. Treatment of extraglandular disease is dependent on its specific manifestation. Arthralgia is managed with NSAIDs or hydroxychloroquine. Neurological manifestations warrant aggressive immunosuppression. Rituximab is considered for severe extraglandular manifestation of Sjogren syndrome such as vasculitis, cryoglobulinemia, and peripheral neuropathy. In patients that have failed medical therapy, a surgical attempt of electrocautery for permanent punctal occlusion may be considered. Moving on to the complications of Sjogren syndrome. Patients with Sjogren syndrome are at increased risk of developing associated conditions such as SLE and rheumatoid arthritis. They are prone to corneal scarring, ulceration, rupture, and infection, ultimately leading to deteriorating vision. Dryness of mucosal membranes predisposes them to recurrent infections. A subset of patients with Sjogren syndrome also experience Raynaud's phenomenon. B-cell lymphomas such as MALT, mucosal-associated lymphoid tissue lymphomas, are also associated with Sjogren syndrome and may manifest with parotid swelling. Pregnant mothers with Sjogren syndrome may experience fetal loss, and the infant may have neonatal lupus syndrome with complete heart block. So to summarize, we have understood what is Sjogren syndrome, which can be divided into primary or secondary causes. There's evidence of xerophthalmia, parotid gland enlargement, and keratoconjunctivitis sicca, and these are hallmark features of Sjogren syndrome, commonly affecting female gender, associated with viral infections and genetic alteration factors as well. To confirm, you would require clinical manifestation or findings with the presence of relevant antibodies and sometimes a biopsy of the salivary glands. Treatment is targeted at symptomatic management as well as looking out for complications and managing them. We have come to the end of this topic. Thank you.